Je moet mij dan introduceren.
Ja. Okay. Okay. We're going to start the next session. We're going to start session 7, the salvage in Dupuytren's treatment when all else fails. Our first speaker is Jean Goubau, who's going to talk about the salvage procedures for recurrent Dupuytren disease.
Thank you, Rosmi, for this introduction. Before starting my talk, I would like to thank Paul Werker for his kind invitation, and Ilse de Greef, of course, to talk about the subject that is not so easy to elaborate. I don't have any conflicts of interest besides a large amount of conflicts of friendship. This is the work of a team. I have, as I call, a scientific community. It's not only in my university, but it's in Flanders and in France. The content on this talk is not very complex. It's about the fifth finger and the recurrent fifth finger, which has been multi-operated. So we'll talk about the indications. I'll talk about something I'm very, I stick very hard to, is the smoking problem of Dupuytren patients, the recurrence, and then the different options we have, because I'm not going to talk about amputation. So the challenging indications we're going to talk about is the recurrence, 2, 3, 4 times being operated. We have now the opportunity to use the echo in our office and to see that there is no vascularity at the palmar side. The stage is stage 4, meaning 45 plus 45 plus 45 plus 45. A very poor, scary, poor soft tissue, and the comorbidities. And I'm going to talk about those comorbidities because since about 15 years, I stopped operating on people who smoke. So they stop smoking. If they don't stop smoking, I will not operate on them. And I have a good, they counsel to the tabacologist who helps them. I screen them with the cotinine dosage to make sure that they stopped smoking. We want to start any procedure in such a difficult situation with the best underlying conditions. So it affects the healing, not only bone, also the skin, endothelial function, etc. So I motivate them. And this is what you get eventually when you keep on smoking. So it's for us very important. And a nice quote, you don't have to have other political ideas in Russia to go to Siberia. In the ancient times, for smoking, you went to Siberia. So I'm not going to talk about amputation because you lose your pulpa. And your pulpa, if it's still sensitive after the multi-operated finger, is a very important part of your function. You don't want cold intolerance with a stump. So to avoid this, to avoid the extra cold intolerance, we're going to try to see what the options are. These are the cases we have, or they are multi-operated, or they have a quality of skin that is not really good, or they don't want to go for any other operation but something that straightens them. The options we are going to talk about is the PIP arthrodesis, the middle phalanx resection, the middle phalanx resection, the proximal arthrodesis, and the proximal arthrodesis with limited fasciectomy. So what do we do when we have a PIP flexum without an MCP flexum or a small, a very light MCP flexum? Frédéric Teboul from Paris proposed a middle phalanx resection with preservation of a joint. It was a case report, and Frédéric Teboul gave me his cases one of his cases to illustrate it. And it's very nice to see how the thing works, because he's been filming the operation, and what you see there, and what is important, he keeps the extensor apparatus. So he's gonna go through the lateral slips at the middle phalanx, and he's gonna disinsert the central slip at the base of the middle phalanx, and retract the extensor apparatus to approach the phalanx, which will be eventually resected. And after resecting it, since we have a good contracture on the volar side, we go for an arthrodesis, a pinning of both, with a reefing of the extensor apparatus. And you have some skin to remove afterwards. You put the pin for about 3 weeks inside. And after that, you get this radiologic result and this functional result of flexion of a P1 with P3. These are a couple of cases. It's not a series, but it's an option we can always retain for salvage of the fifth finger. Proximal arthrodesis proximal distal arthrodesis was first proposed by Goubau and can be used for the same indications without MCP flexum. Goubau was president of the Société Française de Chirurgie de la Main from Angers. It's a very esteemed hand surgeon, I know for many years, and he proposes already on a variation of Mitz, who did a shortening osteotomy already in the early 90s. He modified it by performing a proximodistal arthrodesis by removing P2. And here you see we go through the extensor apparatus, since we don't need it anymore. We then remove the phalanx, remove the articular surfaces, and then the original technique by Goubau was with one big pin or two small pins, but we adapted it really early with a compressive screw, small compressive screw, 2.2. If you have a small finger, 1.7. But since we have the option of having cannulated interfragmentary screws, it's very convenient, and it facilitates early active motion. What is important whenever you perform this operation, if you have seen, we perform an H incision, as was proposed by Goubau. Never remove the flaps or you endanger the vascularity of your finger. So it's important to keep the flaps. In the beginning, it looks a little bit ugly, but it retracts progressively. And as you see here, she has a slightly smaller finger, slightly thicker, but the thickness around the junction has decreased dramatically. And so what we then proposed, and there was a study we did with our scientific group that Bert van Mierlo led in Roeselare. He performed not only this adapted technique of Goubau, but he also added after this arthrodesis, a limited fasciectomy on the palmar side. These are the results. This is one of the cases with the result you have afterwards, with a nice MCP extension. And this is the series that he published in 2023 with, if you compare the DASH score, not a very good improvement, but an overall patient satisfaction that is very good, with 12 out of 13 patients being satisfied, previously well informed, with this functional result. So in a conclusion, I don't like amputation. One of the cases I've ever done, I've never amputated a finger in Dupuytren's disease, but one of the cases I've done was not happy and preferred an amputation after the Goubau procedure in another place. It gives good functional and better functional and cosmetic outcomes. You still have a nail bed. Resection of the middle phalanx without arthrodesis should be considered, because if you had a large contraction, you have a stabilization on the palmar side since you have a contracture, and if you refit well, you can, in some cases, keep some mobility. Finger extension is finger extension is improved as well. The fixed abduction with a limited palmar fasciectomy. And in arthrodesis, we advocate compression screws since it allows early active motion. You can use rehabilitation, physiotherapy, but it's not always necessary. Thank you.
Yes?
Not all together. Go ahead. You have a microphone there?
So my question is the positioning of the arthrodesis. So normally when we do arthrodesis for osteoarthritis, we try to get it about 50-55 degrees because it's a gripping hand, but now you do it straight, and the reason would be?
Well, the reason would be it's easy, and they want it straight because they're frustrated for years that they have a flexed finger. And even the flexion was good, it hinders them. So they are happy to have a straight finger. They don't care about not flexing it anymore, as it should be.
Excellent discussion of some very unusual procedures that many of us probably have never seen or done.
Maybe that's the reason that Ilse invited me, because I'm very unusual.
Well, you've confirmed that for all of us. A question on the resection of the middle phalanx without the arthrodesis. Do you do anything for the collateral ligaments? Even though you're reefing the extensor tendon, it seems like it could be unstable.
Well, you are fortunate enough to have a recurrence that is stiff, taut, that doesn't allow. And I mean, when you examine those people, they have maybe some slight flexion, but I mean, nothing is moving anymore. So that's your partner in crime to try to get this result. And if you have people who say, you propose both options. If they go for one option, it doesn't work out, okay, we still can go for the other option.
Super. Thank you very much.
You're very welcome. Not too difficult, Paul, please. Thank you.
No, thank you very much for showing all this. I just wanted to add, I was inspired by a paper of Atroshi for this middle phalanx excision. Thank you for that. And I tried to put the collateral ligaments together. At least I put in a suture and before I put in the pin. I'm not sure if I do anything
with preserving the joint.
Yes.
Oh yes. That's perfect. Thank you.